Good afternoon, everyone. Hey, my name is Gerald Johnson, and I'm the Executive Vice President in the Office of Health Equity for the American Heart Association, and delighted to be with you today to talk about a topic called good business is good self. And what I'd love to really do is talk about the fact that there's a lot of amazing things going on in the workplace regarding employee health, and want you to know that whether you're a small business, medium-sized business, or large business, there is a compelling people case, but there's also a compelling business case. And we're going to spend a few minutes with you today talking about that. And so what I'd like to do is have my guests introduce themselves, and then we'll get into the program.
Great. Good afternoon, everyone. My name is Dr. Michelle Gordine, and I currently serve as Chief Medical Officer for CVS Caremark. I am a pediatrician by background. I've been in healthcare leadership for close to 30 years. My current position has been effective since December of 2022, so almost 2 years on the job. And I'm responsible for leading a team of about 230 physicians, pharmacists, and other professionals whose job it is to make sure that people have access to clinically effective, low-cost medications to improve their health and quality of life. Delighted to be here.
Good afternoon. My name is Jay Bhatt, and so grateful to be here with all of you. I'm a primary care internist in a community health center in Chicago, and spend most of my time leading Deloitte's Health Equity Institute and Center for Health Solutions. When I think about this issue, I think we've demonstrated that health equity is not just a moral imperative, but an economic imperative to have business solutions, and it relates to our people and it relates to purpose, and that purpose is a modifiable risk factor for mortality, so that if you are engaged in purpose, it has an impact on your longevity and wellness, and we've demonstrated that further through our work. And so really thrilled to talk about good business and good health and how they go hand in hand.
Good afternoon, everyone. My name is Melissa Clarke. I'm the VP and Chief Health Equity Officer at Elevance Health, where I lead our health equity and social impact strategy. My background is as an emergency physician, so I've kind of seen it all right here in DC. And I think really what struck me a lot about being an emergency physician was seeing how people fall through the cracks of the healthcare system, mainly through the convergence of, a combination of low access to opportunities for health, economics, education, and all ending up in worse health outcomes and ending up oftentimes as my patient. And so that really inspired me to move into clinical leadership, population health leadership. I've been doing that for the last 25 years or so, working with payers, state Medicaids, consumers, employer groups, to really infuse health equity into our approach to health and well-being.
Such a pleasure to be here. I'm Shantanu Nundy. I'm a primary care physician here in DC. I work in the safety net, and I'm Accolade's Chief Health Officer. Accolade serves about 15 million Americans, working Americans through their employers, large and small. And I think for me, I come to the conversation, I work in a primary care clinic every Friday, and I just think about so much health and healthcare happens before patients even come to my clinic. And so the opportunity to work with employers and be able to get ahead and reach people where they are, I think is what really inspires me in the work I do. So looking forward to the conversation.
Yeah, so thank you all, and let's just jump in. So for context, if you're wondering why we're here, right now there's 153 million people supported by employer-sponsored plans. And if you think about it right now, we're spending about $320 billion in health inequities. And that's days lost to productivity, that's sickness, that's plans either being used or suboptimized. And when you think about workplace stress, I think we've all been in stressful situations, some days, some weeks, some months, and sometimes even longer, but workplace stress is a thing that contributes to all of that. And if you didn't know this, workplace stress is akin to secondhand smoke. And where am I going with that? Well, secondhand smoke contributes like either likelihood of 40% greater chance of a cardiovascular event or stroke if not undressed. And so when you think about workplace stress, it is equivalent to secondhand smoke in that nature. And so dealing with it, addressing it is incredibly compelling. What I'd like to dig in with my panel today is each have unique superpowers that I want to share with you today. And so I'm going to start by talking about CVS Caremark and talking about benefits. Can you share some of the great things that are going on at your organization that is positioning you all to create great benefits programs for your employees?
So CVS Caremark is a business of CVS Health, which is a broader enterprise. And we are a pharmacy benefits management company. We have a responsibility to provide to our clients who are payers, like employers and health plans and government and unions, the most affordable options in providing prescription drug benefits to their members or their employees. And that's really important because when you think about it, just to the point that you just made, more than 50% of Americans and about 60% of individuals under the age of 65 receive health insurance as a benefit of employment. And so that's sort of the front door to be able to access the healthcare system and to be able to stay healthy. And the pharmacy benefit is part of that, and it really is probably the fastest growing benefit and component. When you think about health insurance and provision of health insurance as a benefit from the perspective of the employee, it really is an important tool to be able to attract and to retain talent. And that's what we hear from the employers who we represent as clients. The total number of individuals that we provide pharmacy benefits management for in the United States totals about 90 million people. Keeping employees healthy, obviously, to the points that you just made, are really important in terms of well-being and productivity and resilience, getting through stressful times. But it can also be an expensive proposition. And we believe that it is more financially positive, and also it makes more sense in terms of the well-being of your employees to keep them healthy than to pay for when they get sick. And so we play a role in terms of looking at prescription drugs. And when you think about the role of prescription drugs, I think about it obviously from the viewpoint of a physician. And it's a really important tool for me in treating my patients who may be sick with an acute or chronic disease, chronic illnesses like hypertension or diabetes or obesity, et cetera, to be able to provide them with access to those medications in a way that helps them to restore their health is very important. But these drugs are only effective if they're able to be used. And one of the most important barriers to any individuals being able to access important prescription drugs they need is affordability. And so that's where we come in. And I'm proud to say that over the last 7 years in a row, our average out-of-pocket cost for prescription drugs for an individual for a 30-day supply is under $8. Let me say that again. The average out-of-pocket cost for a 30-day supply of prescriptions is under $8. So we take that very seriously, and we understand how important that affordability is to access and to good health.
Yeah, Michelle, thank you. But the $8 is the thing still ringing in my ears, so thank you for that. Jay, I want to come to you quickly talking about purpose. Deloitte does a lot of amazing things. Can you talk about the role that purpose plays in driving your health and well-being work at Deloitte?
Yeah, thank you, Gerald. And purpose is central to our work. Deloitte's Chief Purpose Officer, Kwesi Mitchell, leads our Purpose and DEI office. And what we've done from the top of the house, CEO and board level commitment to a number of issues, health equity being one of them, which I lead, along with workforce development and inclusive entrepreneurship or financial inclusion. And we've made a $1.5 billion commitment over 10 years. That includes philanthropy, pro bono, community impact, skills-based volunteering, and all of that work of engaging our people in this work to in the business with the kind of work we do to serve clients, but also in society has made an impact on their ability to feel a sense of well-being and satisfaction. And our survey of Gen Z and millennials that recently came out this year showed that nearly 90% find a sense of purpose critical to job satisfaction and well-being. And the way that we've organized our work at the Health Equity Institute is we've got a theory of change oriented around 3 levers. One is activating key decision makers to advance health equity, and that's the work We do with our World Economic Forum Global Health Equity Network, where nearly 100 CEOs have signed on to a global health, a zero health gaps pledge to advance health equity. The other is fragmented stakeholders coming together around an issue, so maternal health in Philadelphia, the Health Equity Compact in Boston, public and private sector stakeholders. Third is innovation, which is largely focused around inclusive social entrepreneurship. People that have, from disadvantaged backgrounds, those are historically underrepresented, to create social enterprises that advance health equity.
Yeah, Jay, thank you for that. Melissa, I'm going to come to you next. You know, there's the importance of data. You know, I'd love for you to talk about data gaps. You know, they say what doesn't get tracked doesn't get measured. Can you talk about how Elevance is using data to help health equity and drive things in your organization?
Yeah, I think just sort of from an overarching standpoint, first of all, let me say, you know, Elevance Health is a family of companies. You might be more familiar with the names Anthem or WellPoint, which are also in our families of companies in terms of providing health insurance and as being a health plan that really focuses on the health of humanity. And so data is really important. And again, from an overarching standpoint, I think it's important to recognize that having a job that provides health insurance doesn't necessarily protect you from some of the other experiences just of being in society, which is having health-related social needs or being in a group that experiences health disparities. And so one of the roles that we see data playing, whether that's demographic data, race, ethnicity, language, sexual orientation, gender identity data, or demographic data, or data around social needs, we see that as a really key part of understanding what our members need, whether they're commercially insured or insured through our government business in Medicaid or Medicare. And we really use that data to get insights into what interventions are needed. So I just wanted to share some of the data that we have found when we talk about employees. We see that 76% of our commercially insured members have at least one health-related social need. And on average, it's about 1.8 social needs per individual, which is less than our members insured through Medicaid or Medicare, but significant. And about 30% of those individuals have 3 or more health-related social needs, which sort of puts them in our high needs category, which correlates with higher needs in terms of emergency department visits. We see 2 to 3 times the number of emergency department visits happening with that cohort of individuals for things like hypertension. So to your point, Gerald, about higher risks of stroke and heart attack from work-related stress, and also for depression and anxiety. Again, no surprise. And then that's around social needs. And then I'm going to also just refer to work done by Blue Cross Blue Shield and published in 2022 about health disparities within the workforce. We see that racial health disparities, for example, with Black employees having higher rates of high blood pressure, diabetes, higher rates of C-sections, and worse maternal health outcomes. By sexual orientation and gender identity, higher needs when it comes to mental health and depression and anxiety. And then finally, by income, those individuals, no surprise, earning less than $50,000 a year, having more financial stress, especially when it comes to paying medical bills. So I think all those things tell us that the workplace is a perfect venue to start to address some of these health-related social needs and health disparities needs that we see within the workplace. I think we'll be hearing about some solutions on the panel later today.
Yeah, Melissa, you are spot on, and I'm going to open this next question up to the group. So one of the accountabilities to doing this work is bringing other employers with us. And so what I'd love to hear from the group in no particular order is, what are you hearing? What obstacles are you seeing? What would you like to share in what you've learned or heard in bringing employers along? Anyone want to start this?
Well, I'll go ahead and start. I think, as I mentioned at Elevance Health, we really focus on health equity by design. And so as we work with our commercial clients, we really try to focus on how can we help you develop a health equity strategy for your workforce? And one of the ways in which we've done that is to have a social care model called our Community Connected Care Model, or CCC. And it really ensures in that health equity by design and using that social care model that in our policies and programs, we're not creating additional disparities or perpetuating existing disparities, that we're really working to close health disparity gaps. And so our community connected care model, it's comprehensive, it's a social care solution that is really for all members that we serve, including our commercial members. It identifies and leverages the benefits to address health-related social needs that we find for when we outreach to members at risk and find what their social needs are. It leverages our benefits, and if the benefits aren't enough or not specific enough, we then work with community-based organizations to help address those needs. We hire community health workers locally to help do the outreach and engage with members. And the benefit of that is they're lay individuals who are trained specifically around addressing health-related social needs, and they can really know their community to be able to leverage their knowledge of the community to help our members and serve our members best. But they work through a model of community hubs. So there's sort of a central aggregator who has a data platform who can then standardize the collection of data. Again, that data being so important to help us understand and have greater insight into how better to then make our benefits even more tailored to the local community. And then we track effectiveness of the outreach and making sure that it has its intended consequences. Some of the things that we've seen in terms of positive impact include member satisfaction, member retention, improvements in healthcare utilization, so decrease in potentially preventable emergency department visits, potentially preventable admissions, and improvements in the use of primary care physicians. And so I think in terms of bringing employers along, having programs like that that help to resonate with the needs of your employees and really address those health-related social needs are really key.
You know, I would add that one of the ways that we've seen opportunities to advance work together is having the community who have lived experience and are impacted by the work that we do with our workforce or the communities share what they're experiencing. And that sense, it creates this sense of a shared issue that the organizations can come around and say, well, what capabilities do you have? So we had a series of meetings, 4 roundtables, where we started with listening to community first and then having the public and private sector come together to say, okay, what can we do to support what they need? In this case, it turned out to be maternal health, and there were different capabilities and expertise that the different organizations could bring together and to deploy an intervention. Our work around health equity in the workforce with the American Heart Association SHRM Foundation is another example of bringing employers together. And then, for example, with our work around social entrepreneurship, we've brought other organizations that want to support small business, not-for-profit social enterprises around mental health. So if we didn't have those organizations, we'd only support 8 social enterprises, but now we can support 16 and then 24, and because you have shared resources and capabilities and expertise. So I think that that's been one way that we found that be helpful.
Yeah, and as you know, good business, good health sounds like a really good thing to do for all the reasons we've been articulating, but it's not without obstacles. Michelle, I'm going to come to you. What are you hearing? What kind of obstacles, what kind of barriers are you seeing that you could share with the group?
I think what we're mainly hearing from our employer clients are concerns around the cost of care and coverage, the cost of coverage. And so they're coming to us and asking us to be consultative with them on helping them understand, what's best for the individuals who I am covering. So for a particular employer, what's best for my employee population? Kind of piggybacking on what my colleagues have said, data is so important recognizing that 80% of what impacts health is outside of healthcare, they're non-medical factors, is really important. But what does that mean at the end of the day to a particular employer and their group of employees? We've created at Caremark what we call a pharmacoequity tool. And what that tool does is to take a look at our data for a specific employer, for example, and the employees who are covered through a health insurance benefit, to identify who's struggling most in particular disease areas. The first couple of diseases that we've decided to target on are what we call heart and head, right? So hypertension, heart-related, and head, depression, to identify where there are individuals within an employer population that need additional help and additional assistance in overcoming some of the extra barriers that some people disproportionately face in getting well. Barriers like housing, like transportation, like affordability of care. And we made specific investments in those areas in order to be able to support that, but it's a really data-driven, targeted type of approach where we work in partnership with employers to address those issues around coverage and around cost.
Thank you for that. I do have a moment. Shantanu, I know we were saving your assessments for them, but I'd love for you to weigh in on this. What kind of barriers, what kind of obstacles are you seeing?
Yeah, I mean, I think one of the biggest ones is just we have to start with what we have, right? I think like we all operate in environments where maybe we don't actually have data by race and language and ethnicity, right? We might be in a place where we don't really clearly can articulate what the business case is for things. And I think what I find as we talk to employers around the country is, let's just start with what you have, right? Most employers, for example, have access to claims data, right? And so we've been able to look at claims data and say, well, can we measure how strong of a primary care relationship each of your employees has, right? We could actually look at it and say, well, if you're someone who every time you go to the ER, you see your doctor right afterward, we would probably guess that you have a better primary care relationship than someone who goes to the ER and doesn't see their doctor afterward. So let's start with the data we have and construct measures that help us understand that this is a population that's more marginalized than another, and then sort of rinse and repeat from there. That's what we see folks starting to do, is building that sort of confidence to be able to tackle what's oftentimes seems to be a very intractable problem from the seats that they sit in.
Yeah, thank you for that. This is going to be to a couple of you. You know, one of the things that the partnership that we have, the American Heart Association with Deloitte, has created is a 10-point action plan. And in it, it really talks about compelling ways that you could advance health and well-being in your organizations. I'm going to ask each of you to briefly, if you were thinking about those 10 points, what one or two jumped out to you that you'd love to share with the group? Jay, I'll start with you.
Yeah, I think one is this notion of thinking about it enterprise-wide in the context of your business and design. So we did some analysis that looked at women 19 to 64 in commercial health plans and men, and saw that women pay $15.4 billion more out of pocket for healthcare costs. Now, when you add maternity care, it's $17 billion. So it's the way that the system designs benefits and structures to lead to those outcomes. So think about a screening mammogram. If you find something on that, you have to go get a diagnostic, which may or may not be covered, or different symptoms that have to be addressed differently. So that's one example of, when we're designing, to the point that was made about health equity by intention and design, Melissa, that's one area that I think is really powerful in our set of strategies.
Melissa, I'm going to come to you.
Sure. I think it's the last one, about implementing workplace health and well-being benefits and policies and programs that are intentionally designed to promote equitable employee outcomes, health outcomes. And I picked that one. It resonated, obviously, because of the statistics that I mentioned up front. I always say, again, key is the use of data. We've developed something called the Whole Health Index, which is a 90-point description of a person's health, and then we were able to assign a score to each individual that's covered, and de-identify and aggregate that data and map it by counties at the county level. So many of our employer clients are actually using that information to understand where can I make impact, large-scale impact investments in my community to improve the health of the community as well. So that would be an example of a program, for example, that might not necessarily be employee-specific, but is community-based to be able to make impacts on the health of the community, because we know zip code is more important than genetic code that when it comes to health outcomes. And I would also say that you need to measure how well you're doing. And so also as part of that playbook, there are the top 5 outcome metrics that I think that we need to follow along: employee perception of health and well-being, employee sentiment on belonging and diversity, equity, and inclusion, promotion and pay parity data following that, employee feedback on satisfaction for health benefits and health benefit utilization. I think following those metrics will help give you a sense of how well am I impacting the health and well-being of my employees.
So I'm going to give you the last response to this particular question. What say you?
So the bullet in the framework that talked about embedding health equity in all of the work that we do really did resonate with me for a couple of reasons. One, CVS Health has made a commitment to health equity and has not just placed it in the hands of our Chief Health Equity Officer. While she's extremely capable, Dr. Joné Caldoun, the expectation is that it would permeate in every single business unit that is a part of CVS Health. And so with Caremark, certainly it permeates in all the work that we do. So looking at the formulary decisions that we make on behalf of in conjunction with our clients, the utilization management programs to make sure that the safest medication gets in the right hands at the best cost, paying attention to whether we are unintentionally, certainly, perpetuating health inequities becomes extremely important. And so that's why when we learned earlier this year that the Utilization Review Accreditation Commission, URAC, which is extremely important to all the work that we do as a PBM, introduced a health equity accreditation, we raised our hand. Because we feel that not only should we believe that the work that we are doing is paying attention to not perpetuating health inequities, but we wanted to get that independent external validation that we're providing care of the highest quality, and there's no healthcare quality without healthcare equity. And so we are proud to say that we are the first healthcare company to achieve URAC Health Equity Accreditation, and we believe that it's really a stamp of approval and really a demonstration of the commitment that we have within our PBM to health equity.
Yeah, thank you for that. And I'm just going to briefly add one additional one. At the very top of those 10 points is this notion of creating comprehensive, affordable, and understandable care that includes mental health services. And so if you think about making it comprehensive and getting input from your employees, that's half the battle. If you make sure that it's affordable, that'll address the issue of the thousands of people that have care, but they can't afford copays. And if you help make sure that it's understandable, folks will use more of the very plans that you spend money on. And then I want to double down on what you said around embedding it into your organization. It isn't a bolt-on. It is integrated into everything that you do. This notion of equity lives across everything that a business does, and want you to think about that. And so Shantanu, I'm going to come to you. You've had a chance to listen to a bunch of the conversations. Yeah. You yourself are involved with a lot of employers and do a lot of great things. What would you offer to the audience that really summarizes a couple of things you think would be great to really advance health equity in the workplace, good business, good health for the audience?
Yeah, I've learned so much from the panel. I mean, I think I'd say a couple things. One is, I think implicit in a lot of what we said is health equity matters for employers, right? I think there's still a notion out there that, oh, that relates to Medicaid or that's Medicare, that's not us. I think what you heard very clearly is that there are massive inequities within commercial populations. I think the second thing we heard is that there's a huge business case for it, right? Whether your employer is talking about retention issues or talent issues, whether they're talking about the cost of medical care, or whether they're talking about the community itself, all of those have a huge health equity lens that create a sustainable business case for investing in it. In terms of the investments themselves, I think what we heard is health equity by design. Like, we have to think about those disadvantaged, marginalized communities first, not last, and we have to build for them, and then we have to ensure that we have data that helps us be accountable to the results that we're trying to achieve. And I'll end with my friend Dr. Bhatt's, one of his favorite sayings is, if not us, who? And if not now, when? And so it's been a great conversation. Thank you.
And Shantanu, I'll just add, the point you made around the business case, it's a flywheel, right? It's the sense of, we just put out an analysis that shows that if organizations and businesses, the private sector lean into health equity, you can create nearly $3 trillion more in value to the GDP and $760 billion more in corporate profits, which then can be reinvested into the work of social impact, the work of supporting the health of your employees, and create situations where people and the business thrive. And so that's also something I wanted to lift up to follow on, Sean. Thank you.
Yeah, and so I'm going to close one. Thank you all for listening to us, but wanted to remind you that there is a compelling people case for this, right? Better employees, healthier employees lead to preferred brands, employer brands of choice. So helps you on the end of your brand that you care a lot about, which is turnover and productivity. I also want to remind you that as of today, $320 billion is being spent on health inequities. That means that we have an opportunity to do something about it. And left unchecked, it's going to get to $1 trillion and counting. So if you're responsible for the bottom line in any way, I'd ask you to think about that. And then lastly, I did say something to you in the front end of this. We spend about 1/3 of our time at work in our lives. We will spend about 1/3 of our time at work. And the workplace represents an amazing platform to do amazing things. And so if you want your employees to stay, to do amazing work, it's been validated that happier, satisfied, healthier employees perform better. And I just want you to know this work that we're doing isn't just amongst us. We'd love for you to think about taking up the mantle, doing more than what you're doing today. If you want help, either of us, any of us, all of us are willing to share things that are going on. We mentioned the 10-point strategy. All of that is free. It's democratized. It gives you the opportunity to say, wow, whatever we're doing today, great, but have we thought about this and have we thought about that? And then it also provides you ways to measure it. So on behalf of my panel, thank you for the few minutes today. And with that, I'd like to say thanks.